Dr. Orel Swenson, welcome to the Vagina Doctor Podcast.
Thank you very much, sir. Good to be here.
Great, good to see you. You're a board-certified emergency physician, turned regenerative medicine expert, trained at a level 1 trauma center and formerly on the front lines at Johns Hopkins. You now fuse regenerative medicine with cutting-edge science, especially focused on optimizing cognitive function and physical performance and extending health span. You run a thriving business in Boston, recently expanded to Montecito, bringing a high-touch, tailored approach to Southern California. You're a professor at the Geneva College of Longevity Sciences, an advisor to the American Heart Association, and a Duke MBA. That may be your best qualification, actually.
I like that the most.
Most
useful.
It's much more useful than medicine. Your work sits at the intersection of elite medicine, peak performance, and next-gen health strategy. In discussing the plan for you to come, when we talked previously, I was immediately struck by a philosophy that we share. And it's about pushing boundaries and not just for the sake of pushing boundaries.
Right.
It's more about questioning what we know and being open to evolving thoughts. And you mentioned that you've noticed a kind of curiosity that we have in medical school early in our experience that can fade after training ends. And there's a disappointing statistic, and more than disappointing, it's tragic, that on average it takes 17 years for a new standard of care to be adopted. I hadn't actually heard that stat previously, but it's true. It's just, it takes so long to change things if we're going to wait for all the powers that be okaying everything and having evidence-based medicine as they want. Now, there's not any reason not to use evidence-based medicine when we have it, but we shouldn't have to wait for that. We should be able to be sensible and think about things. That pace just not satisfactory when we're dealing with people's lives and quality of care and quality of the life. So it's not so much just pushing boundaries, it's refusing to settle for a system that often resists progress. Not about being radical, it's about being honest about what's working and what's not. I used some of your words in that. So we just agree completely with that. So we're on the same
side. Now we share a philosophy,
all
yes,
right,
sir.
So today we're going to discuss, among other things, lifestyle impacts and the limits of lifestyle impacts. Because most people, when they're trying to improve their life, they think, okay, I've got to eat better, stop smoking, stop alcohol, and exercise more. And those are all important, but it's not the only thing. So there are some restrictions in that, or it's not enough. Basically.
No, exactly right. I think taking your audience as it is for this podcast, most people recognize the basics, right? They're doing the best they can 9 times out of 10. It's certainly what I've seen in my practice. Individuals that are coming in, they're 40s, 50s, 60s. They are executives, they're athletes, they're entrepreneurs. They're very high-performing individuals to begin with. And whether they have the time to make additional lifestyle modifications or not is usually the issue. They are aware of, I should be sleeping more, or I should be exercising more, or what VO2 max might do for me, etc. But they've maxed out for any number of reasons. They travel 26 weeks out of the year. They have to get up at 4 o'clock.
And
happens.
They get older.
Right.
That's
exactly. So on top of the aging aspect itself is the fact that the farther along you get in your career, the busier you tend to be, and the less time you actually have to do all these lifestyle optimizations. So while it's certainly true that if you're not checking the baseline boxes, you're missing out on low-hanging fruit, it's also not going to be enough. You can't keep running and running until, phrased differently, no matter how much you run to improve your VO2 max, you still, to your point, getting older, getting slower. Your cellular function is degrading. Your ATP is not being generated as efficiently because your body's breaking down. But we have a number of tools to slow that much more drastically than healthcare, I think, has thus far embraced. And this is where, of course, we would get into peptides and exosomes in particular for how they affect that process, to say nothing of more advanced supplementation processes.
one of the things that came up in our discussions is aging itself and why you made the statement that's less linear than we previously thought.
Yes.
Explain that a little bit.
Yeah, so we often think about, okay, well, every year I get a little older, and so I must get a little weaker. But we've found, we as in scientific community have identified that when you actually look at aging and you look at step down in muscle mass, for instance, or decline in your circadian rhythm and loss of sleep, It does happen in a much more dramatic manner at certain points in time. I wouldn't quote an exact age per se, but for instance, some people wake up, oh, I finally feel 30, or I can't believe I feel 50 today. You've heard statements like this. And in fact, it's real. It's because there are decades in life, and we often think of them around late 30s, early 40s, late 60s, and then 70s to 80s as being large step downs in your quality of life. As to the reason behind that accelerated process, I don't know it. There might be information around it, but I'm not sure as the why behind it.
Okay. Well, it's certainly one's experience in that time. There is definitely a linear aspect to it, and in waves, I think. Certainly, there are times when you do feel really good about yourself, and then times when you don't. And sometimes the whole aging can be accelerated by something that you did for the benefit of your health. Let's take a hip replacement, for instance.
Right.
It's, I have pain. I want my hip to work better. I don't want to hurt anymore. And I have surgery. And yes, I am better. My hip doesn't hurt anymore. And I'm mobile. But I lost that time of the recovery where it was really hard to come back up. After.
That's what I found too. Like even I had the flu recently and it just devastated me. My strength and my endurance. I mean, just being sick for whatever, 2 weeks.
2-3 weeks.
Yeah.
It was like starting all over.
Yeah, I mean, because the retention of, and you're aware of this well, retention of muscle mass is minimal. That's to say, you begin to lose muscle mass very quickly when you stop resistance training. You have a slightly slower degradation of VO2 max and cardiovascular capacity, but you see it anyways. And then, of course, there's the carry forward from anything, in your case, the ongoing inflammation, et cetera, hits every organ system, slows you down for a while afterwards. It's not just that, oh, I was sick and I had a runny nose. And your whole body experiences the inflammation, right? Gut health goes a little sideways for a while. All those systems have to heal and recover, right? Your body's trying to heal all those systems, not just the runny nose. And so too with respect to the hip, right? Mm-hmm. You're down for 90 days, you're down for 6 months of minimal activity, all that muscle loss, degradation, loss of mobility, your muscles are tightening up in that time. Now you stand up and you can't move as well as you used to, despite your best efforts. And again, to the point of, I certainly get people, 48 years old, this is a client last week. I swear I could get better or recovered faster from my weekend pickleball just 2 years ago. And it's that kind of thing of, all of a sudden you seem to slow down in your healing process and everything hurts a little more and for a little longer because your body is depleting all of the resources it otherwise utilizes to repair DNA, maximize ATP, maximize cellular function. Well, those things aren't as efficient as they used to be because you've burned through them after 50, 60 years of being alive.
Oh, wait, I want to talk about something.
Go ahead.
So all that being said, and factoring back in what you said previously with peptides, I want to start there with peptides. Is that okay? Is that what you were going to say too?
Yes.
Okay.
Yeah.
Fire away.
So if we're factoring peptides to all these problems that we're all facing with getting older, I want you to speak to what that looks like, what they're doing, how long they take to work, what is the upkeep and the commitment with peptide therapy.
Yeah, so I think it's important to preface this with a few exceptions. Most peptides that are being utilized are considered research grade. That is, we're not even in like human trials just yet. They're being used in people off-label. And it's a worthwhile disclosure, right? Because we don't have the same type of controlled trials that we've seen with other medications.
We're not going to live long enough to get those trials.
Exactly.
In some cases.
No, that's exactly right. So when we talk about, this is actually a perfect example of limitations that cut both ways. So let's say it's 17 years for a new drug to get approved, a new standard of care, as we mentioned earlier.
Yeah.
Okay. If you want to wait 17 years to begin using these peptides and you're 50 years old or 60 years old, that's a substantial amount of lost time where your body could otherwise be optimized to get more peak performance. However, that comes with loss of data or lack of data in that respect, and we're stuck taking animal models and extrapolating the best information we can from them. So there's certainly a different level of risk in that space. But conversely, we've had millions of use cases of peptides being used in humans now. We just don't have that same approach to it. And one last statement before we get into the mechanisms of the how behind it. To your point, living long enough, so some of these peptides that we'll get into have shown dramatic increases in life expectancy for a mouse. That might map to 30 or 40 years longer in a human. We don't have time to run a 30 or 40-year clinical trial, and there's no way to get clean data out of that anyways. So there's not going to be great data in the peptide space anytime soon. So I'll pause there and then kind of revisit what you were asking about.
Yeah. Just first of all, what is a peptide? Just explain
absolutely. So
to our listeners.
Of course, for anybody that doesn't have the background for it, peptides are nothing more than short versions of proteins. And I say proteins that your body uses to communicate, not the kind of proteins that you eat, at least for the sake of conceptualization. They're just shorter in the amount of amino acids, so they're just not as long. From a functional perspective, you can think of them somewhat akin to hormones. They have broad-reaching impacts when you take them. Your cells use peptides to communicate all the time, and they don't communicate just one message at a time with these peptides. They say, well, if we're going to make more growth hormone, we also have to increase our metabolism. We also have to increase this to build more muscle mass. So they have multiple effects simultaneously. That said, there's categories that they fit in. So to your first question, by and large, at least from my perspective, I categorize them as those that improve healing and recovery, those that improve cognitive performance, synaptic plasticity, brain health, those that improve your muscle mass and strength, and typically some metabolic increase there as well. And then you might consider them in the cosmetic space that drive the production of collagen and elastin to improve skin health, although there's evidence that it also improves health of other body organs, unsurprisingly, because there's collagen in joints.
That makes sense.
Right.
Yeah.
Weight loss drugs that are popular right now, Wegovy and Ozempic, are considered a peptide. There's some glutide derivative, of course. I didn't qualify those in kind of these other categories, so to speak. And then there's a few that benefit sexual health as well, particularly one that you're familiar with, I'm sure, is PT141, as well as oxytocin that can be utilized to drive up attachment and sexual health and increase desire, quite frankly.
And for anyone wanting to address everything that you just mentioned, especially from what we hear, like cognitive health is just huge right now. People feeling that brain fog, especially menopausal patients.
Yep.
Adding a peptide in, what does that look like?
Yeah, I try not to be too generalized about it, right? Because I think exactly what we're trying to get away from with respect to traditional medicine is a much more tailored approach and customization behind that. And what I mean is this. There are several different categories of peptides that play in the cognitive space. There's actually many, but several that are being used commonplace. Some can improve focus while having an anxiolytic or relaxation type effect. Some improve the development of synapses in the brain itself. And then they can be supplemented or supported by what they call nootropics, which is just a fancy way to say supplements that seem to have a tremendous impact on brain health more than anything else.
Yeah.
Which one is right for a given individual, as you can probably now appreciate, has a little bit of finesse to it beyond that. So we'll go through a cognitive performance test, potentially along with a EEG cap to understand, all right, what's working well for you, what's not, where are your missing domains in terms of, are you having short-term memory issues, is executive function, are you just not sleeping well at all? And this is a whole other conversation to start before we even go down the peptide route from that perspective.
So that's just since we segued into that. So the patient experience with you starts with a lot of testing.
It starts with a robust intake. So we'll sit down for 90 minutes. Before that, I'll have reviewed their medical records. We sit down and we go through everything with respect to their lifestyle consideration, their goals with working with me. What do they want to get out of this? Not everybody's the same, of course. What have they tried so far that worked? What's failed? And what kind of timeline are they operating on? Oh, I have a big board meeting next week. What can we do before that? Sometimes there are a few things we can do. We're not going to fix everything, but there's a few cheat codes to be had at that point. And then we decide, okay, based on all that, what is the appropriate approach for you with respect to lab testing, cellular function testing, biometric data points, cognitive health, et cetera. Things like VO2 max, muscle mass, all factor into this. All tests that are very well established, have substantial credibility in the scientific community, but often are outside this, let's say, scope of a primary care doctor, mainly because of time constraints. Once you have all this personalized information, you have to formulate a very personalized plan. I can't walk in and say, all right, here's the antibiotic, and I'll see you later. We have to sit down and go through all this data that is unique to you and does not fit into an algorithm.
Do a lot of patients get to you because they're like, I feel like I'm doing everything right here, and I'm still just not where I want to be?
That's exactly it. They're showing up saying, why am I losing a step? I'm supposed to do I'm taking my multivitamin every day. I'm going for a run 3 times a week,
I'm
I still don't have the same energy, and it's this much harder. And every morning it takes me forever to feel like I'm on point until 3 cups of coffee in. It used to be 1 cup. It's all that kind of thing that comes together. They've often not exhausted, but certainly gone through even concierge primary care, where they're getting good testing done, they're getting good levels of insight. They've maxed it all out, and now they're looking for, how do I stay at my peak?
What do you know about quantitative EEGs in terms of looking at the brain in another way, out of the norm? There's most people on their annual exam aren't going to get a quantitative EEG, right. But what can we see there that would be,
or should they be?
But yes.
So it's something I've gone back and forth with utilizing. I'm actually happy to have your input on this as well, but in so much as it's a fun data point to get for people, showing effectively the speed of nerve processing. It's a second level of objective data. To be frank, I see the EEG as a very useful motivational tool for people. Look, your synapses are firing at 10 years older than they should be, so to speak. Again, I'm being a little arbitrary in the definition here. We really need to address this beyond the fact that your executive function testing is showing some slowing. Here's an additional point suggesting that what you're experiencing is quite real. To your direct question, do we need quantitative EEGs? Again, I've gone back and forth, and I would work with somebody, I often offer them whether they want it or not, because it's not necessarily directly actionable. We have this, we know that things are slowing down, but if you're telling me you have brain fog and I have evidence that you have executive function loss, we're going to address it regardless. But some people really like to have that data point and to see what's happening.
Yeah, there is an organization in town, Orel Therapy is the name of the company, and they really have an action aspect to their findings. Okay, this is what we found. This is what we can do about it. So it has been more than anybody else that I've spoken to, even neurologists actually, that they have been much more focused, that neurophil therapists have been much more suggestive of taking action on this than the neurologist who just says, you're fine, or you're where you should be for your age. That's not the point.
No, it's not the point at all.
For the age.
Yeah, but like you said, you're going to, regardless of what this test shows, you're going to listen and treat those symptoms they're having regardless.
And so I think that's often the case. Is there's always a bit of a balancing act with respect to testing for the sake of testing, and not that's what they're doing. I'm just commenting that there's always that consideration versus is it actionable enough? They have things that they're taking action on that are informed by the EEG specifically versus other cognitive testing, and certainly that's a respectable approach.
Yeah. There's so much that can be done, and it can really be expensive too to do the testing. Unfortunately,
yeah. Again, it's one of those things that economies of scale has not caught up with that, of course, because health insurance is not covering these things. And so that's the way of industry.
Yeah.
Are there any, just one more thing about the peptides. Okay. Are there any risks associated with peptide therapy?
Oh, for sure. Yep. I have very complete conversations with any client with respect to their risk factors. We'll go through more dedicated screening questionnaires looking for, again, any family history, personal history suggests they should not get peptides or would be a higher risk for. Other outcomes, one of the big ones that's floated often is, of course, a cancer risk. And the reason behind that statement is because if a peptide makes cells grow, it makes all cells grow. It doesn't have knowledge to say this is a cancer cell and this is not a cancer cell. So that's the biggest risk behind them. Now, whether or not that risk is substantial, it's certainly not large by any of the data that we have to date. Is it negligible? Maybe, but I would never say that to a client, so to speak, with respect to, we truthfully don't know. We only have, much of this is based on, as I mentioned, animal model data. Extracting that, no, who knows? You're not a mouse, so you're going to react differently. That's probably one of the scarier risks behind them. Then, of course, allergic reactions. Peptides, also worth mentioning, most of them have to be done by subcutaneous shots you can give yourself. A few are available as nasal sprays, and a very few are available as dissolving ones under the tongue. Be very wary of those selling oral peptides that you take as a pill because your body is designed to break down proteins. So it doesn't really survive the gut very well.
Okay.
Good point.
So if you're doing the injection therapy for peptides, how often do you get those done?
Hugely variable. It depends on
Okay.
the peptide and the outcome that you're looking for. Some can be done daily for 6 weeks, 8 weeks. Others are done 2 to 3 times per week. There's a few that can be done a couple times a day and then you cycle off. In my case, and what I always promote is, regardless of the peptide, that we are going to cycle you off at some point, whether it's a month or 3 months, etc. Recheck labs, make sure things are not changing that would otherwise be red flags of why are we seeing this lab change or that lab data point change. We're going to stop the peptide at that point and go from there. So there's mechanisms in place, so to speak, to offset risk to a degree, but yes.
Let's go back to a little more vague but perhaps simpler discussion about supplements.
Sure.
Daily. Given our lifestyle, let's just say here in Montecito,
Good place to be.
good place to be, got sunshine,
Yes.
and maybe too much of it sometimes. What's this sort of a sensible daily regimen for somebody who is active? I mean, I push the protein in my diet, so I'm looking for personal recommendations, and you can charge me for it.
First one's free, it's fine.
What do you suggest? I mean, just broad spectrum, just a big.
Yeah, that's
big
fair.
paper.
So again, unsurprisingly, without giving I'm going to give a canned answer anyways, but
Yeah, okay. All right.
which is I'll always test labs, see what you're deficient in, et cetera. So they're not giving you a generic blueprint. Don't go take your 1-a-day multivitamins. Probably not what you actually need, more than likely. 90% of the U.S. population approximately is thought to have vitamin D deficiency. So that's a bit of a no-brainer for most people. Honestly, after that, it gets a little more nuanced. Some have abnormal liver enzymes despite not drinking, so we'll put them on acetylcysteine to protect as a liver protecting agent. Many people have inflammatory biomarkers by and large, but giving generic advice like taking fish oil supplements is a little risky because there's some data behind that if you don't have cholesterol issues and don't have inflammatory issues, fish oil might actually drive increased risk of cardiovascular disease. So one of these ones that everybody thinks is benign that isn't.
Yeah, that's wild.
Yeah, it's a newer data point. I think I saw the study maybe 3 weeks ago. I haven't read the whole thing yet, though, so I don't know the full nuance behind it. So vitamin D is a no-brainer for the majority of people. Almost everyone could benefit from some type of pre- and or pre-probiotic supplement, and that's based on the American lifestyle more than anything else. We're subject to lots of ultra-processed foods, no matter what. Even our organic, as most of us know, is not actually organic and still has pesticides and all sorts of things. So it's unless you're someone who's telling me you religiously eat kefir and sauerkraut and kimchi every single day, and that's the mainstay of your diet, there's a good chance you could benefit from some sort of pre- and or probiotic support.
There's just so many out there.
Yeah, there are.
It's so confusing.
Yeah, there are. And then, I mean, you can get gut health testing done to give a much more nuanced approach to if you have signs of a leaky gut, elevated zonular levels, et cetera, that show, or you actually really need more advanced or intense gut health and gut repair support mechanisms.
Is there a biomarker that patients really obsess over that they really? Is there one thing where people come to you and they're super obsessed about a lab or something where you're like, yeah, you don't really need to be worried so much about
high
that.
sensitivity C-reactive protein.
So the one that I've seen tested for, yes, HSCRP, high sensitivity C-reactive protein, is an interesting one because it varies and fluctuates quite a bit on a daily basis compared to regular CRP or C-reactive protein, which is an inflammatory marker. But the one that I've caught people going a little nutty over is their cortisol levels. And they'll do the morning and evening cortisol swabs. They'll get it done and send it in, and it's off range or it's high or it's low. I'm like, it fluctuates dramatically. I mean, you have to reproduce the exact same circumstances on that day to get the same result the next day. Did you sleep the exact same amount? Did you have coffee before the deal? All those things factor into that. And people see cortisol as a marker of stress, rightfully. It's relevant if it's way out of whack, but if you're off by what we consider the semi-normal range, probably not worth worrying about just yet.
And actually, this is a tangential thought, but
No worries.
relative to that is adrenal insufficiency or adrenal failure. Okay, well, I mean, so many people come in, my adrenals are gone. You know, just,
It would be interesting to see.
Yes, exactly. It's not really what's happening.
Yep.
But I mean, it seems to me that somebody that's continually stressed is potentially can burn out adrenal function, or at least not burn it out, suppress it.
Yeah, so this gets into a kind of a contested area of what a phenomenon called cortisol steal syndrome, which is chronic elevated cortisol levels effectively force your body to shift production to cortisol. And in so doing, you reduce production of many other hormones, including sex hormone binding globulin, testosterone. Everything goes sideways. It's argued because the legitimacy behind it is argued because your body theoretically can just upregulate everything and make more of other hormones if it's deficient. But I think the take-home point is that high levels of cortisol for prolonged periods of time, high stress hormones, show up in other ways. Well, we do see reduced testosterone levels. We do see elevated cardiovascular risk. If you do a coronary CT scan, et cetera, you start building up plaque. We do see elevated CRP levels, gut leakage, because now we get into the gut-brain connection, how the hormones that affect your mood actually also affect your gut absorption profile and vice versa. So it all begins a much more complicated process from there.
Which leads me to ask the next question, which we ask people a lot. What's your opinion on statins?
Statin has a lot of historical good safety data around it, despite emerging other questions that are coming out. I mean, all medications should always be questioned, right? Everything we do, that's the whole point of medicine science, should be questioned and challenged over and over again, that what was considered standard of care once upon a time ago will not be standard of care in the future. PCSK9 inhibitors are gaining tremendous traction for good reason for their effects, though they are argued to be better performed in conjunction with statin therapy. So for those who are on statins right now, I would encourage you to continue taking them as it is, as we identify more research with respect to what their real safety profile, other considerations are. There are alternatives, but there's no reason to immediately believe they might not have other factors that we haven't discovered yet either. PCSK9 inhibitors have not been around for 70 years worth of data.
Yeah.
It's always a trade-off, right? You want to kind of highlight this one shortcoming or several shortcomings of statins, but we've only discovered them after many years of having them in the public domain. Who's to say what else we'll find with novel agents? My 2 cents.
Yeah.
Well, relative to statins too, I mean, a lot of the testing that's routinely done by primary care physicians and even gynecologists is not very deep. I mean, there are tests such as apolipoprotein B and lipoprotein(a)
Yes,
that they're just not looked at very frequently. And in the eyes of the believers, that those are really important lipids.
They are, in my opinion, as well.
And patients say to me all the time, because I do incorporate those, particularly in the weight management patients, but in the peri and postmenopausal patients who are considering going on hormone replacement, I'm looking at that as well, because I want to be sure we're not increasing cardiovascular risk to those patients. And I mean, the comment is, I've never had that test before. Okay, in your 50 years of life, you're probably right. It hasn't been done
I'm
before.
sure.
And so it's again one of those things that takes 17 years to come into normal.
Although an interesting call out, ApoB has been pretty standardized in most European countries for nearly 20 years. So we kind of missed the ball on that one. I'm not quite sure why.
Oh, really?
Yeah. They've been using it much longer than we have. Again, not sure why. But yeah, you're right. There's a lot of these that haven't been done before. And I think unfortunately, that's one of the biggest problems that we get to is, well, it's a novel test, right? And this is where regenerative medicine space and anybody pushing the envelope a little bit has to be very candid with their clients, no different than the peptide conversation of limitations of what we currently know on this brand new test that we have. Here's what we think we know about ApoB, and we're pretty sure it means this. Here's what we think we know about LPA, and we're pretty sure it means this right now. And we don't know it all, though. So I'm giving you the best treatment I can offer based on the knowledge. It's very different than what we've kind of adopted as a semi-parental role for the typical medicine interaction. Right? I walk in, I know exactly what needs to happen. Here's your, let's call it antibiotic for the sake of simplicity. Here's your medication. I walk out, we're done. This is much more conversation-based. Here's what we think we're going to do. Are we going to skip the statin and start with the PCSK9 because your LPA is through the roof, but your other markers are okay, but borderline? Is that a reasonable trade-off? Here's what we know, here's what we don't know. It requires a patient, a client, pick your term, that really wants to be involved in their care process as well, because it's not we know everything. I mean, they're all out there listening to the same podcast that we are.
Yeah. Yet patients, they're able now to do so much research on their own that it's good and bad sometimes.
Yeah, no, I mean, it all things can cut both ways, of course, but I think I'm actually going to steal from Dr. Viglione. Everybody comes to this with their own biases. I come with a Western medicine bias and training, everything else. So as we approach a more cutting edge field, it's worth having those biases challenged. Everything that you assume or you went to med school learning about, it's not all right. We're aware of that. Patients are aware of that as well. They don't have the background that I have for certain things that might be considered obvious to me. Conversely, they don't have the same biases that I have when it comes to something new or novel because, well, I was ingrained in Western medicine for X many years.
Yeah. But for anybody searching out this type of performance medicine like you do, you are new to Santa Barbara.
Very much so.
And you're getting everything set up you're currently seeing patients that you've had for years.
Yes. Yep.
And anyone wanting to start the process with you, what would that look like?
Yeah, so as it currently stands, still up and ready to take patients. We have a small office space here in Santa Barbara already.
Great.
So we can do consultations. We can do some basic treatments. We can have mobile phlebotomy with respect to lab work and advanced testing done in patients' homes or at the clinic location itself. Some of the much more advanced testing, unsurprisingly, it's going to come once the full commercial space is set up. We'll replicate much of what we were doing in Boston here, of course. But tailored to your point, some of the differences in lifestyle here with respect to year-round outdoor activity and people who are generally more active here than on the East Coast, just by nature of where they live.
Okay.
But yeah, it starts off with consultation. If they have questions, we do complimentary discovery calls. I get on the phone, chat with them for 20 minutes. What is this? What is the process? What happens, et cetera. And then full intake. And we design, all right, what are the next steps? What are we working towards for you?
Great.
And is this process, it's continual, the work they do with you, or does it have a start and end, or is everyone different?
So it's meant to be continual, but recognizing that most people want more objective endpoint, right? This is, I think, part of the challenge for the longevity space, and I would say regenerative medicine fits under longevity, is that no one wants to be told you're going to work with a longevity doctor for the next 70 years. I mean, that doesn't really make sense to say that. Where are the end goals for improvements? To your question, most people are seeing me on a membership basis. They continue with me for a long period of time where there are periods of advanced testing, there are periods of just ongoing consultation, but we're usually striving towards defined end goals on where should we be at 3 months, where should we be at 12 months. What slipped. And unsurprisingly, by the time we hit 12 months, something new has risen because that's the nature of life and things have changed. Yeah. We correct one thing and something new crops up. But there are kind of canned, or not canned, I shouldn't say, but the defined end goals that we can strive towards for those who say, look, I really just want to focus on cognitive health for the next 3 months. If this works, we'll go from there. It's certainly feasible. I do plenty of those, I would say, packages, so to speak, for lack of a better term.
I need to come see you for that.
And when you say we, who does that mean at this point?
It's myself. I have a head of concierge medicine. I've got a couple of nurses, both in Boston and now here in Santa Barbara as well, for some of the IVs, shots, etc. But as far as the clinician, it's just me at the moment.
Okay.
And I mean, if in a perfect world, aging would be classified as a disease, which would need ongoing treatment.
Right.
So it makes perfect sense that it would be ongoing treatment. If when you reach a certain age and you're breaking down, whether it be mentally, physically, and you need that person, that practitioner to treat the disease. So I would think, really it should be looked at completely differently.
I think that's the beginning that is happening now.
Yeah.
I think that's what you're an example of this. That it's not like you've got this knowledge, you wonder what to do with it. You know what to do with it.
Yeah.
It's just time consuming and expensive to do that. But there are things, it doesn't all have to be expensive.
No, not at all.
There are simple things that can be done. But it's definitely becoming more popular. And because our life expectancy is longer, and we don't want to be just a vegetable at that time. I mean, you can keep me pumped up and keep me going, but if the brain goes, not much point.
Yeah.
And so I think that there's a huge market for this, and but it is an understanding that is ongoing and it's improvement.
Well, it's a huge
slowing down.
mindset shift for potential patients because by and large, you go to the doctor when you're sick. And that is the end of the conversation. Once I'm not sick, we're done here. There are a few examples, but even the existing examples, for the most part, so let's take heart disease, right? A patient who's going to see that cardiologist forever. They're still sick. They're seeing the cardiologist because they're checking on their heart specifically. They're not seeing somebody on okay, what do we need to uncover? What am I missing below the surface here? Theoretically, that was the idea behind primary care, but at least for the US, we've gone very much in a different direction with primary care, unfortunately, for a plethora of reasons that I think we probably don't need to get into because of how much it'll derail us. But to your point, yeah, it is a continuous investment in your own health, which we accept when it comes to exercise. Okay, if you exercise every day, it's probably good for you. If you eat right every day, it's probably good for you. And now we need to begin redriving that mentality around healthcare. If you see your doctor every 6 months and get the advanced testing and everything else and do, the gallery testing, the Grail gallery testing for early cancer detection or explore other imaging modalities, et cetera, it's probably good for you. There does need to be a continuous relationship. And of course, ironically, the more we adapt that mentality, the cheaper this becomes because things will be reaching economies of scale and there'll be more options out there in terms of treatment tools, and then peptides won't be this novelty that are hard to get, et cetera. And
because it seems like for us at our practice, we're a cash pay practice, not concierge, but a lot of the work we do is similar to concierge medicine.
Yep.
But for patients coming through for hormones, they're used to paying monthly for their hormones, and they're dealing with a lot of brain fog and fatigue. Yep. And we're getting them back, or he's getting them back on track. However, sometimes I feel like there is a piece that's more what you do to work with what we do, because one person can't solve the whole problem.
No, that's exactly right. I think it's a very relevant call out. The reason that I say that I focus on cognitive performance health is that's because what I focus on. I am not a therapist. I am not a gynecologist. I am not a cardiologist. There's a lot of things that I don't do. I'm not a physical therapist. I give you some of the tools to improve, for instance, joint healing and repair after an injury. That's great, but you probably still should go see a competent physical therapist who can effectively tell you how to use the tools. All right, your tennis elbow is getting better faster. Great. What do we do to stop it from happening next time? So to exactly that point, there's a niche component to this, and it requires no different than anybody else, other experts to take over the portions that I don't do.
Yeah, and that we don't do.
Exactly.
Because we're not doing peptide therapy in the office. However, we get so many people asking about peptide therapy. But the problem is that there's a lot of these things that are getting saturated in the marketplace. People are doing them that are not qualified to be doing them. They're using troches, which you kind of
some can be okay. Like I said, there's a few that are that do work for sure, but some are absolute nonsense. Others are just taken as pills. I've seen people have asked about actually taking peptide pills, and it's not going to work.
Yeah.
And I think what you're getting at, unfortunately for us, is whenever you're at the cutting edge of anything scientific, there's always the charlatans out there, and unfortunately, that invites people who will inevitably have a bad experience, and or drives, I don't want to say regulation. Regulation can be good, but it can drive the wrong kind of regulation that stops the advancement. Right? Somebody has a poor experience because they're being seen for peptide therapy by a random individual who doesn't really know what they're doing in that space. Something bad happens, and we set this field back 10 years very easily. And that's always a risk.
Just something springs to mind with that a dysfunction or a problem with regulation, particularly as being FDA and compounding pharmacies.
Yeah.
Because there are a lot of good things you can do from compound pharmacists.
Oh, yeah.
And getting medications into the body safely and better than other ways. We've seen that in hormone replacement therapy. Clearly safer than oral or actually to a large extent probably injectables also. It's just, I was at a conference for the North American Menopause Society, now just called the Menopause Society, and they were talking about replacement hormones for vasomotor symptoms and putting a little bit of lip service into dealing with preventing osteoporosis and cardiovascular health, but they would not touch transdermal compounded creams. Now, it was okay for the pharmaceutical company to do a topical application of a gel, but the compounding pharmacies were they actually said, no, they're not FDA approved. End of story. I'm thinking, what are you thinking here? This is safe. It's been done for millennia.
Yep.
And it's it's slowing the whole process down, and it's increasing the risk of using alternative methods.
Yeah. And I mean, let's be clear, like 503A and 503B compounding pharmacies are regulated industries with extraordinarily strict standards.
Oh, yeah.
And of course, they undercut large pharmaceutical companies in many ways. I mean, they have to get FDA approval for drug in shortage, so to speak, before they can produce. Yeah, there's a whole bunch of,
Not quite the same strength of drug that's available from the pharmaceutical companies. That's another way around it.
Or you combine with a fairly inert additional compound, so to speak.
Yeah. So it's just different.
One thing I love about this podcast is we get a chance to really collaborate with a lot of different people in town. Obviously, Dr. we've known for a long time, and we share a patient and just adore him. And you're a close friend of his. You guys, right?
Med school together, yeah.
Went to medical
school.
So
we've known each other for
a long time.
A long time.
A long time, right?
Yeah. And I know we talked about you meeting Dr. Dennis Hughes. Did you ever meet him?
I have not met him just yet, no.
Duncan.
Yeah.
That's not his fault.
No, but seriously.
I can fix this.
No. He also is close with Dr. Viglione and helped, as we did, get Dennis kind of going a little bit here in Santa Barbara.
I mentioned last time.
But I definitely want you to meet him. But having this community of people that we can work so closely with our patients is just so valuable. So I'm so happy you're in Santa Barbara.
Yeah,
I really appreciate that.
Having
Thank
someone
you.
like you here, I think we can really weave this into what we're doing.
Yeah, absolutely.
I sincerely appreciate that. No,
Yeah.
I think, I mean, to your point, it requires that collaboration. I mean, part of why I was drawn out here was because of Alan Viglione, his knowledge in this space already. Now I have a primary care doctor who understands this, who is not a blocker. And so too with you guys, like understanding what else is happening and not having to educate the provider before educating the patient is a huge step in the right direction. Okay, now we can have a conversation of, are we doing the right thing? Well, this is what you need to do, and this is what you're seeing with her, and this is what I'm seeing with her.
That information, being able to get the patient into you quick.
Yep.
Me being able to text you and saying, hey, I got this person. It's so important.
Now that I unsilenced your text messages, sorry about that.
Yeah. I don't know what was happening there. I'm like, what happened? Did he like leave?
Oh yeah, no, I was that offended after our first meeting that no, I'm kidding. I don't know. I'm sorry for that.
That's okay.
I've referred a number of patients to Dennis Hughes, and everybody's been really appreciative of his ability and his knowledge. So I was describing him to a patient when I said, he's a lipid nerd.
He's very specific, like types, but not a nerd at all.
No, but
just
a patient said that to him, but I can describe it. And so he sends me a text when I hear you referred to me as a lipid nerd. I'll take that as a compliment. I said it was intended that way, really.
Exactly.
It was just how to prepare the patient. It's just.
I don't want to keep you for too much longer, but there are some things on your form that we asked you to fill out that I wanted to discuss, because when you first reached out to me, I reached out to Dr. Viglione, and he described you exactly the way. How would someone close to you describe you?
Oh, okay. Well, that's good to know.
That you're always in motion, that you're physically or whether physically or professionally, that you're always in motion. That's exactly what he said, that you like to keep engaged. And
I really love talking to him with the headphones and the microscope, in the microphone.
Yeah.
Because I can hear more clearly what you're saying. And it's brilliant. I love it. So all conversations can be this way.
It is nice and clear, for sure.
Yeah.
And then the other question is about pushing boundaries. Is that part of your original makeup, or did life experience make you this way?
Yeah, like I said, I guess I don't see it as pushing boundaries. I just, quite frankly, feel like you're supposed to continue to innovate. And I know this is a callback to the beginning of our conversation, but it always struck me as odd that people, very high-performing physicians, right? You get into med school, you go through residency, you go through these great programs, you land in an attending physician job, and many people, I feel like, stop pushing the envelope at that point.
Absolutely.
Like they just
Yeah.
settle in. And it's confusing to me because they go from a very much so alpha type A personality to, I guess, contentment, which I understand the reason behind that. But yeah, I guess I just don't see this pushing
The
boundaries.
world needs both kinds of people, I do think. But yes, I think you are either one or the other.
Yeah. Like I said, I haven't seen it that way, but it seems like others do.
Yeah, I mean, I feel like there are those jobs that do take that acceptance of this is what I'm doing and I'm doing this each day.
I think OBGYN is one of those places. Actually, the OB part has changed significantly with more knowledge about fetal maternal physiology.
Makes sense.
Definitely. But in gynecology, it's hardly changed at all since for 50 years.
Yeah.
Hormones are still not. I mean, so much of the time, I will have patients that I have on hormone replacement therapy that have, for one reason or another, gone to see a gynecologist in a big clinic, and they'll say, you need to come off those now. And that's not the working theory with this. It's contrary. It's extremely difficult. And Santa Barbara is very conservative in that regard. Not just gynecology, but the medical society here is very high powered, but nobody that's really pushing the envelope or really taking everything into consideration and on all of the new stuff. I thought that looking at it as OBGYN, that we have this level of knowledge coming out of medical school and we stick to that for so long. And if we've been out in our practice for 30 or 40 years, are we really still practicing 30 and 40-year-old medicine? And unfortunately, in gynecology, that's the case for a lot of people. It's just really has not progressed. I mean, now we have more subspecialties, so people are focusing on certain things like pelvic floor surgeon. Okay, there is a subspecialty for that. It's really just that the average person coming out is doing routine OBGYN, which patients don't need us to deliver their babies, frankly. They could do it all themselves, or particularly with a midwife. I couldn't have stood in that regular OBGYN practice in Santa Barbara for 45 years, which I've done. I mean, I had to change.
Yep.
It pushed me to change. It was always interest. Something exciting is happening here. Now it's hormone replacement, regenerative medicine. But for a lot of my career, it was a minimally invasive surgery.
Sure.
And it took so long for that to get into, or even though gynecologists essentially started it, the old minimally invasive stuff, through infertility specialists primarily and endometriosis. But trying to get those gynecologists trained in a traditional manner to try to learn a different operative technique, it took 20 years until the robot came around and made one difference in GYN surgery, which is you could put a stitch in and tie a knot more easily than you could in the straight stick. And it only changed because the pressure, when 2 or 3 people started using it, when the robot came along, everybody jumped on the bandwagon because being a robotic surgeon sounded better.
Yeah, it's always confused me that medicine seems to be reluctant to that change. And then you can go down a lot of rabbit holes, right? As I mentioned a little earlier, this is a very different kind of medicine. I'm sure you see it too, which is a much more collaborative approach. You have to be very comfortable knowing that you do not have all the answers when you walk into the room. And you're going to be asked questions by your patients that you don't have answers to. That's not how we're taught during med school. So there's that mindset shift, right? Which is a big challenge, right? And a big way to change your thinking, And of course, there's always the argument of, well, medicine should move slow because lives are at risk. And there is certainly a validity behind that, right? We do want to have as much data as possible, but lives are at risk when we don't move as well.
Really?
When we're not making changes and quality of life is going straight downhill and when we're not intervening upon that. And even that statement of, oh, well, lives are at risk doesn't stand up to quite as much scrutiny as you'd like to think it would. If you're an aerospace engineer developing the next rocket or the next whatever, I don't know, I'm not an aerospace engineer, whatever they're developing, people are flying in these, right? And lives are at risk. But they're encouraged to push the boundaries and move faster and be at the cutting edge and get there. We don't have that mindset in healthcare. I don't really know why.
Yeah. And another thing that we forgot to ask, or it was in my mind to ask you, and it kind of goes along with this, is exosome therapy.
Sure.
How are you using exosomes? Another controversial topic.
Yes.
We get asked questions all the time about exosomes.
Yep.
That is pushing the boundaries, and there's lots of different messaging surrounding it.
Yeah, so I think probably a quick comment as what is an exosome might be relevant for the audience because it's fairly poorly described to this date. And I'll do my best to describe it as well, also knowing I probably won't nail it. Quite simply, exosomes are if you think of cellular communication happening on all different channels, so let's say your cells can talk by sending a text message, phone call, an envelope, or a FedEx package. The exosomes are a FedEx package, and in that package is a whole bunch of different information simultaneously. Many of it in current use cases around anti-inflammatory. So we do have exosomes that drive reductions in inflammation and promote repair. So effectively, it's the messaging that your cells are sending to each other. We're just stealing the FedEx packages, putting a whole bunch of them together, concentrating them so they can all the signal at once of reduced inflammation. Their use cases theoretically are far broader than have been explored to date, but at least in my practice, I limit it to, for the most part, joint, muscle, bone, tendon health, recovery, repair areas.
Okay.
There are many studies actively going on about what other use cases exosomes have. They can be using the same FedEx package example. We can edit what is in the package such that it can deliver other growth factors in that.
Yeah.
Exactly right.
Hair loss.
Well, so even those are still using something of a generic exosome for now, but we're getting into the space where they can trigger repair of, for instance, myocardial tissue and things like that. But that's still pretty early days. So what we have that we know is safe and working is in the joint health, muscle, and tendon space. And that's where I largely limit it to in my practice.
Okay. So
I have an official definition.
Fire away, sir.
Yours was actually better, but it's a membrane-bound extracellular vesicle carrying nucleic acids, proteins, lipids, and metabolites, 32 to 150 nanometers in size, involved in cellular communications. And one of the bonuses with it can't self-replicate.
And that's actually a relevant last comment, yes, is that it does not grow, it does not contain DNA, so they're very safe from that, but it does not contain RNA either, given some comments out there, as we all know.
yeah.
Yep.
So you're using it primarily for patients that present with pain, or
It's for injury and
inflammation?
repair.
Okay,
Yep. And yes,
repair.
though it can be used for pain per se, it's not being used for pain directly. I'm not using it in the setting of pain. I'm using it, okay, you have obvious and established injury, osteoarthritis, etc. We have a low-grade tendon tear. You have a partial cartilage disruption. You don't want surgery. Exosomes are a step in that direction of what's maximize your body's own healing potential by giving it all the tools, essentially. If you keep going back to that FedEx package mentality, all right, here's all the tools that your 60-year-old body is no longer producing in order to repair. So it's that kind of kit. It's not stem cells, which are new cells that can grow brand new all over again. So that's a whole other conversation. And it's not peptides, which are just driving intrinsically what you can release. It's kind of that next level up, so to speak.
Right.
How busy is the exosome part of your practice? Are people really searching for exosomes now? Is it becoming more mainstream?
You have to find out in Montecito, obviously, in terms of that as I'm building out here. In Boston, small demand, but Boston's a unique creature, right? When we talk about the pushback, I guess, you think about Harvard and Yale and all those. That is the Boston kind of mentality of, well, my primary care doctor who's at Harvard said, don't do this, or this is nonsense. Mm-hmm. It's an argument you're not going to win. It's just a non-starter. And so there's not that openness to that, which certainly slows down demand for it.
Good. There are a million other.
I know. I want to talk about.
That'll be chapter 2.
Yeah, I want to know more on his fun fact.
Oh well, actually, I want to talk about that. You're a mailboat captain.
Yes.
For 5 years.
What is a mailboat captain?
Just what it sounds like.
Okay.
It's a mailboat.
Yeah. So it was Skinny Atlas Lake, upstate New York. So don't quote me too much. I wanted to say it was one of 3 or 4 mailboats in the U.S. at the time when I was doing this, still in service. And effectively, it meant this. Half of the lake, it's a 16-mile long lake, half of the lake to this day does not have road access. at all. So the only way to get the mail there is by boat. And the post office still has an obligation to deliver the mail based on what's a U.S. address with a mailbox, except the mailbox faces the water.
And what's the time frame on this? Before you were an ER doc?
This was before ER. This was through college and part of med school. Yep, before being an ER doctor for sure. As we discussed, a job that maybe I shouldn't have left. I mean,
wait, which one?
The mailboat. I mean, I spent all my days driving a boat on a lake in upstate New York. I'm pretty sure that's what I'm aspiring to accomplish now.
Exactly. Very similar to the Tofino situation.
Oh, okay, yeah.
So the mailboat went up from the mailboat. It was not just a mailboat. It was a mailboat and also a grocery boat and all the other things that came in. Or a supply boat that came up the coast. And one of the stops, which was Cougar Annie's place, just in a house north of Tofino. And she was the postmistress of that area. And so that was very interesting because we lived with those things for a while.
Yeah.
But the other one that I liked about was one of your ER experiences where you were the only doc around.
Yeah.
For what distance and
a while. Yeah, so there were actually a couple of them. They were freestanding emergency departments. So ERs that operate either completely independent of a hospital or in either case, without a hospital physically attached to it. So the difference between them and an urgent care is you're still offering all the emergency services. So that level up of we can treat a heart attack and a stroke and everything else. Maybe even I'll keep you here for 24, 48 hours, figuring out transfer. And I did this in Texas. That was a tough job. That was
that sounds like
those shifts were anywhere from 24 to I think my record breaker was 52 hours. That was long enough.
Are you watching The Pit?
No.
You lived the pit.
I refuse, exactly.
Yeah, exactly. Too much anxiety.
Yeah.
Wow, that's amazing. But you must have seen so much.
Yeah, I mean, these are like rural areas, unsurprisingly, where interestingly, the scope of injuries was, as you might expect, right? Farm, car accidents, that kind of stuff. Right. But I spent plenty of time in the inner city as well. I was at Lifebridge Hospital after Johns Hopkins, inner city Baltimore area, all the, as they would say, knife and gun club mentality. So saw enough.
Yeah, well, the other similarity to Tofino with that is that this little town halfway up Vancouver Island was that there was only a population of about 1,000 people in the town, but there were the logging camps all around. There were the Indian reservations. There's a fishing fleet, and there were then 10,000 tourists that would come on a weekend for the national park right there. And car accidents every weekend,
of course.
But strange things that we do. Well, I mean, okay, somebody from the fishing fleet, well, they had their hand caught in the ice maker, or the ice crusher, I should say, and come up with this mangled limb. Just incredible experience. Learn more there than I did in my residency.
Yeah, that's exactly right. I mean, once you're on your own and you there's no backup whatsoever, you're okay. Yeah. Well, yeah, it was good.
Well, this has been great.
Really fun.
Great. So
thank you.
It's Aonic Health, right?
Yes.
Great.
Yep.
And we'll put links to get in touch to you.
Thank you. I appreciate that.
On the episode. So
awesome.
It's been really nice.
This was very fun.
We're going to talk more.
Great.
This is just the beginning.
I'll
still
have to introduce you to Dennis Hughes.
So. Sounds great, sir. Thank you.
Something to do.
All right. Good.
All right. Thanks so much.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.